I get the job to talk about extravascular lung water and translate the physiology which is behind into some practical aspect that we have when we measure this value in our ICU. So I would like briefly before starting, because I think it's crucial to understand how delicate or how sensitive extravascular lung water is on changing, to review briefly the fluid homeostasis at the level of the lung capillaries. Then I would talk about the assessment of the extravascular lung and review some older works that have been done. It's always good to go back to the history and see what previous physicians and researchers have done to better understand what's going on. Then briefly talk about validation of extravascular lung water and then the clinical evidence. If we go back and think what are the forces that drive fluid within the lung, then we have to consider three things. First of all, the hydrostatic pressure. This is obvious. And the hydrostatic pressure in a normal lung is very low. It's around 7 millimeters of mercury. Then we have a negative interstitial pressure that acts in the lung because the lung is sitting in the thorax and needs to be open, and therefore there needs to be a slightly negative pressure that also helps to increase the vascular pressure, the driving pressure of fluid outside of the capillaries. And then importantly, and we sometimes forgot about this, you have a colloid-oncotic pressure as well in the interstitium of the lung. And this is not that low, it's 40 millimeters mercury. So at the end you have a driving pressure of fluid out of the capillaries, which is around 29 millimeters mercury. And this fluid needs to go back. And the lymphatic vessels you have within the lung cannot cope with 29 millimeters of mercury of fluid. And so you need an intravascular colloid-oncotic pressure to gain back the fluid within the lung capillaries. Some difference remains there. And for this, to cope with this difference, the lymphatic vessels are there and then can drain quite a lot of fluid and so help to keep the lung dry, but they can be afforded and then fluid start to accumulate within the lung. If you have tumor cell, for example, within the lymphatics, then you get the typical figures that you can see in a CT scan. What is the critical capillary pressure that makes that the fluid remains in the capillaries and doesn't move out? It's around 20, and this is something that Guyton showed already in the 50s. As soon as the critical capillary pressure is exceeded, the fluid content within the lung is increasing. This is something that we could reproduce many years ago in HAPE susceptible subject and could show that HAPE arises when this critical capillary pressure is exceeded at the level of the capillaries. Then if you have an increased permeability of the vessel, as you find in sepsis, for example, the critical capillary pressure may decrease to 15 or even lower. And you know that many of our septic patients are hypoproteinemic as well. Albumin content is low, and the critical capillary pressure decreases even more. And this is the rationale which is behind the strategy that we follow to our day to keep dry our RDS patients. This equilibrium is described by the Starling equation that we'll go through into detail, just to remind you that this equilibrium is described within this formula. Now, something that we forget frequently is that the lung has a capacity to keep their alveoli dry via other mechanisms that we sometimes forgot and are important. So we have in the lung alveolar type 2 cells, and these alveolar type 2 cells are important transporters of sodium from the alveolar space into interstitial space. And this builds up an osmotic gradient that drives water out of the alveolar into interstitium. If those channels here our activity is decreased, or you go to hypoxia and the content of those channels are decreased, fluid starts accumulating in the lung. And there are several situations that we face in our patients that act on this transport of this transporter of sodium at the alveolar level, cellular level too. So we have inflammatory response, inflammatometer that decrease the epithelial transport of sodium, and we have a stress response, our catecholamines, that activate this sodium transport. And this is an important balance that we have to consider. There were studies trying to activate these sodium channels with beta-2 agonists or meteorol, but unfortunately they were not successful for the treatment in RDS. Let's come now to the measurement of extravascular water. This is something that has been done already 20 years ago and started to describe this phenomenon. And an article that reviews very nicely this process and the work that has been done is down here in the American Journal of Applied Physiology, and tells you two things. To measure extravascular lung water, you need a double indicator technique. This was the initial concept, where you have indocyanine green and thermal dye that are combined within one surge. And you inject a certain volume to the vessels, and these two indicators go and travel through the thorax and are detected in a sensor at the level of the femoral artery. And you have at this level, you record two curves, a curve for the dye, indocyanine green, and a curve for the thermal effect. Why the two? Because indocyanine green binds to albumin and remains in the vessel itself. And the thermal effect distributes across the vessel barrier and distributes in the at the interstitial level. So the intrathoracal blood volume is the product of the cardiac output time the transit time of the indocyanine green curve. And the total water content of the thorax itself is the cardiac output time the area under the curve under the thermal space. And the difference between the water content in the vessel and in the total gives you the extravascular lung water. And this is how extravascular lung water was measured until the end of the 90s. If we go further on and think what are the other effects that can be measured out of a thermodilution curve or an indocyanine green curve, are the downslope volumes. The downslope volumes of both curves indicate the water content of the largest of the cavities that are crossed by the indicator. And you have the product of the cardiac output time, the downslope time, gives you the volume of the blood in the lung itself. If you multiply the cardiac output times the downslope times the thermal curve, you get the volume of the thermal volume content of the lung, including the interstitium. The difference then between the intrathoracal thermal volume and the pulmonary thermal volume gives you the volume of the cavities that are outside of the lung. And this is the so-called global anastolic volume. I give you this value because it's important to understand the next step, which is the step of single thermodilution technique, which we are using nowadays in the devices that are provided. But before I'm going to this point, let me remind you an important thing, something that I have already expressed here, to show you that the downslope time is different between, depending on the size of the chamber itself. If the largest chamber is small, then the downslope time is much more steeper. If the larger chamber is broad, the downslope time is less steep. And this is something that has been described already in the 50s in patients with cardiogenic pulmonary edema. You see this patient is arriving in the ICU with a decompensated state, and his downslope time was very flat at this time. He get diuretics, and water could get out, chest rate improved, and the downslope time was much steeper. So an important thing to remind also is that the downslope time is a marker of fluid content of the lung, or how much fluid is in the lung itself. So how did we come to the fact that in our days we don't use anymore the double indicator technique to assess extravascular lung water? This comes out from a work from Neumann that has been published at the end of the last century, and he calculated two things. First of all, you have here the formula for the double indication, what I told you before, to calculate the intrathoracal blood volume and the extravascular lung water. Then he said, I have the single thermodilution technique. If I just use water, cold water, as a dye to calculate extravascular lung water, then I have to do the following things. I have the intrathermal volume content of the thorax and the pulmonary volume content of the thorax, which are given by the formula that I just mentioned. If you then take the relationship between extravascular water calculated by the double dye-dilution technique and the global end-diastolic volume, which is nothing else, the difference between the thermal volume and of the complete thorax and the thermal volume of the lung, then I can try to figure out and calculate what it is the intrathoracal blood volume. And this equation of the relationship of this relationship gives you the possibility to calculate this value that you need to calculate extravascular lung water. So at the end, the extravascular lung water in a single thermodilution technique is calculated subtracting from the total thermal volume the intrathoracal blood volume that you estimated thanks the formula of the relationship. And he could show in animal model that this was quite a good relationship, and he could predict extravascular lung water using a single dilution technique with small confidence standard deviations. And it's thanks to the work of Sacca at the beginning of this century that this technique became available in our ICUs and was there to be validated. And he found that the correlation in humans, the correlation between intrathoracal blood volume and global end-diastolic volume was very narrow, and that the intrathoracal blood volume could be calculated multiplying the global end-diastolic volume by 1.25 and adding a 28 milliliter of mercury, so it's a mistake, it should be a plus. And how did he come then? He looked to the correlation between the now calculated, estimated intrathoracal blood volume and the intrathoracal blood volume that was measured by the double indication technique. And he found, again, a very good and close correlation between these two things. So the way was open to show that the extravascular lung water, when it is measured using a single technique, it is equivalent or near very close to the extravascular lung water that we obtain using a dual dye technique. This concept of single thermodilution technique has then been validated in animal experiments, and I show you here one of those experiments that show it nicely and clearly, the two effects. First of all, the strong relationship of the extravascular lung water with the extravascular lung water measured by gravimetry, and this in a different condition, in controlled condition, in animals where receive oleic acid, a model of RDS, and animals where a balloon was inflated in the left atrium in order to increase the venous pressure among the lung and simulating so a cardiogenic pulmonary edema. In this model, he could also show that there is a relationship between extravascular lung water and interthoracic blood volume, and the relationship between these two are valid methods to assess the permeability leak of the RDS, which was not the case for the hydrostatic pulmonary edema. What is the validation in the our days in the clinic? This is one of the studies that shows you nicely that the extravascular lung water, particularly if you now normalize it for predicted body weight and you not take the actual body weight, can so very nicely distinguish between survivors and non-survivor with a severe RDS, which is much better than the extravascular lung water itself, and it correlates with the lung injury score. Jean-Louis Teboul and Xavier Monet could show nicely, were the first to show that this applies also for patients with RDS and hydrostatic pulmonary edema in the ICU, where the pulmonary vascular permeability index was significantly lower in hydrostatic edema compared to cardiogenic edema. And this is something that we use every day in our ICU. We look in the days after a patient has been admitted because of cardiogenic edema, how fast clears extravascular lung water, and if extravascular lung clears less than 10% within the next days, then the outcome of those patients are much more poor. In summary, what I have shown you, I have shown you that the fluid homeostasis in the lung is a delicate equilibrium, that we have to know and take care of it, that the measurement of extravascular lung water is the gold standard, the double indicator technique, but in our days, a single indicator are giving good values that we can use and are validated in the ICU. And in the clinical application, we have many work showing nowadays that extravascular water can be monitored to see the success of your treatment and assess the prognosis of the patient. Thank you very much.
Thank you, Marco, for the presentation.